Okay, well, we've got still a few people filtering in, but we have ticked past 7 o'clock, so we might make a start. So good evening, everybody, and welcome to tonight's webinar. Thanks for joining us tonight to talk about the National Cervical Screening Program. We're going to talk tonight about how to optimise the use of self-collection in your practice and follow up your patients' results. My name's Hannah. I'm from the ACPCC, and it's my pleasure to be chairing this session this evening. And a big thank you to the Northwest Melbourne PHN for the opportunity to partner with you on this event. So to begin, the Australian Centre for the Prevention of Cervical Cancer and the Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Bunurong people, and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping. Throughout the webinar, all attendees will be muted, and we will have time for questions at the end of the presentations today. Please place your questions, please ask your questions via the Q&A box as shown on this slide rather than in the chat. Your questions will be asked anonymously as the session is being recorded today. So the Northwest Melbourne PHN uses the Zoom participant list to mark attendance for CPD purposes. So please ensure that you have joined the session using the same name as your event registration, or your phone number if you've dialed in. If you're not sure if your name matches, please send a chat message to the Northwest Melbourne PHN Education to identify yourself, make sure that you get your certificate and CPD points. So to introduce our speakers for this evening, our first speaker tonight will be Dr. Alexis Butler, who is a GP liaison physician at BCS Pathology, which is a division of ACPCC, which is the Australian Centre for the Prevention of Cervical Cancer. Alexis has extensive experience in providing cervical screening advice, and if any of you use BCS Pathology, you may well have spoken to Alexis in the past on the phone. Alexis also has lots of experience in providing education for healthcare professionals in roles at Peter MacCallum Cancer Centre, as well as previously at the Royal Children's Hospital. And she's also worked as a GP in family planning and in mother-baby units for many years in the UK and in Melbourne. And our second speaker this evening will be Dr. Ella Elwood-Shoesmith, who is a GP in the inner north of Melbourne. She's got a special interest in women's health, and she's the clinical editor at Health Pathways Melbourne, and has been involved in recent updates to the Health Pathways cervical screening pathway. So I will hand over to Alexis, but before I do, just to let you know, we will have a case study at the end of this presentation and some questions, which will pop up on your screen. So we'll ask you to select an answer for them when we come to it. Answers are all anonymous, so jump in and have a go, even if you aren't sure. So just look out for that when it comes up later. So with no further ado, I'll hand over to you, Alexis, and let you take it away from here. And you'll need to unmute yourself.
Right, thank you, Hannah. Thank you for that lovely introduction and getting me to unmute myself, which is always helpful. And as Hannah says, I'm a GP liaison physician at BCS, and I've probably spoken to some of you on the phone about your cervical screening issues, and because that's our raison d'etre at BCS, is to help you with any cervical screening problems. And please feel free to call if you have any issues. And also on that note, I'd like to acknowledge that there's probably a very broad range of knowledge of cervical screening experience in the audience today. And so if there's anything that you don't follow, either feel free to put a question in the question and answer and we'll address it later, or you can always phone us at GP Liaison at BCS if there's something you want to discuss. Or the other option is that we also do education visits to practices, and these even come with CPD points, so we can always help you with any of your cervical screening issues through one of those if you like. So on with the show. So tonight I'm going to do a brief overview of self-collection, and then I'm really going to go through things sort of chronologically, as if you were approaching offering and doing self-collection. So I'm going to talk about who you might offer self-collection to, what you would advise them, what equipment you would use, where and how you would do it, and sort of a bit about result follow-up through a case study. These are the learning objectives. Okay, so self-collection, as you know, is a simple vaginal swab. It tests for HPV. It does not test for cytology. And as of July 2022, it can be offered to all eligible screening participants as an option instead of the clinician-collected sampling. It always has to be ordered and managed by a healthcare professional. As you can see, it was taken up quite promptly after the policy change, and interestingly, the physician-collected CSTs didn't drop off too much. So we're kind of hoping that a lot of these self-collects were actually under-screened participants who took up this opportunity. So who can you offer self-collection to? Basically, you can offer self-collection to anyone who requires an HPV test on its own at any point on the cervical screening pathway. And that will obviously include your usual 5-yearly interval screening for negative HPV tests. It will also include the 1-year follow-up HPV test for after a normal or SIN1 colposcopy biopsy result. Of course, if they have a high grade in treatment, that's a different kettle of fish, and I'll go into that later. That requires a test of cure. But if the colposcopy biopsy has been normal or SIN1, they will just require an HPV test at 1 year, and that can be a self-collect. You can also offer self-collection for the annual follow-ups after an HPV not 16-18 positive, if they have normal or low-grade cytology. Now, on that, I'm just going to take a deeper dive into the cervical screening pathway and into HPV not 16-18. So this is a diagram, really, of the merged pathways of self-collect and clinician-collected. And as you can see here, we only test, as you know, for the oncogenic types of HPV. And there are believed to be about 14 types of HPV that are oncogenic. And of those, the worst offenders, the most likely to cause progression, are the infections caused by HPV 16 or 18. And participants infected with 16 or 18 will be referred to colposcopy. However, the remaining 12 types are grouped together under the title of HPV not 16-18, and they're considered to be much more indolent and much less likely to progress. But we still need to triage them and monitor them. So initially, they have a cytology triage, and I'll go into that in a little later on in the talk. But basically, if that's high grade, they'll go to colposcopy. But if it's normal or low grade, we want to give this group of women the opportunity to clear their infection, because we know that 90% of HPV infections will clear in 2 years. So we monitor them by asking them to come back in a year for a repeat HPV test. And at this point, you can do a self-collect for this test. you can offer them that. If they're not 16, 18 at this point, positive still, and their cytology is normal or low grade, they can then be offered another test in 12 months. If that one is positive, the infection is beginning to show persistence, and we have concerns that it's getting more oncogenic. So regardless of their cytology, they will be referred to colposcopy. Now, this pathway is actually for the normal or lower risk population. If the woman is considered to be of high risk, and the group that we consider to be high risk are women over 50 years of age, Aboriginal or Torres Strait Islanders, or women who are underscreened. These groups are all more likely to get cervical cancer, so we have to be more careful with them. So with this group, they will actually be referred to colposcopy on their first positive HPV follow-up result, so their second actual positive test, rather than the third one. So, of course, for any screening, it's important to check that the patient is actually due for screening, because otherwise the test will not get a Medicare rebate. But it is useful to know as well that most labs do actually give some leeway on the screening interval. And I know, for instance, at BCS that we allow about a 3-month leeway. So for instance, if somebody comes for their 1-year follow-up test at 9 months, you can process it and they will get a rebate. And the same if they came for their 5-year test, they came at 4 years, 9 months, the patient would still get a rebate if you did the test. However, having said that, of course, it's obviously better to stick to the correct screening intervals if you can, but it is useful to know that. Now, if you're not sure whether they're due or what their screening history is, you can access the registry. And the easiest way to access the registry is if you've got software that will link to it. And the software programs that will do that are Medical Director, Best Practice, and I think one called Clinicare. However, if you haven't got software that's linked to the registry, you can actually contact them on the phone, or you can create a Proda account and check on the history then. Of course, the group that we really like you to proactively screen, and who are really appreciating the self-collection, are the underscreened group. And it's really important to try and get hold of them, because 70% of cervical cancers actually occur in this group. And it seems that self-collection is highly acceptable to this group. Not only is it highly acceptable, but they actually also comply really well with their follow-up if they have positive HPV results. However, studies have shown that they do need more support if they're underscreened for those further investigations. And of course, self-collection is a very useful tool for the quest of eliminating cervical cancer, which the World Health Organization has launched as a target. And in fact, Australia is on track to achieve elimination of cervical cancer by 2035. So I've gone through who can be offered self-collection, but who shouldn't be offered self-collection. And basically, that's anyone who needs a co-test. So anyone who needs cytology and an HPV test. And of course, both these tests can be done on a physician-collected ThinPrep, but only the HPV can be done on a self-collect swab. So who needs a co-test? Well, basically, the largest group who seem to get co-tested are those patients that you consider have symptoms that require further investigation to exclude cervical cancer. And according to the guidelines, those symptoms are things like unexplained vaginal bleeding or unexplained persistent or unusual vaginal discharge, not short-term vaginal discharge, but discharge that you're really unsure what's causing it and it's been going for quite some time. Short-term discharge obviously is more likely to be something like thrush or some sort of sexually transmitted infection. Isolated symptoms of dyspareunia are not commonly associated with cervical cancer, and according to the guidelines, don't really require a co-test to be ordered. The other group of people who require co-testing are women who are under test of cure surveillance. And these groups of women are women who've had high-grade biopsies at COLT and had treatment. These women are more at risk of a high-grade recurrence. So unless they go through this test of cure, and basically this test of cure consists of annual co-testing until they have 2 consecutive negative co-test results. Then at that point, their risk of recurrence is back to normal and they can go back to normal screening intervals. Less commonly, you have people who are under surveillance for adenocarcinoma in situ, and they actually require co-testing indefinitely. This may change in the future. We haven't got so much information or statistics on adenocarcinoma. So at the moment, you know, to be on the safe side, we monitor these, we will be monitoring these cases until we do have more information. The other group that has co-testing as part of their investigations and surveillance is those who've been exposed to DES in utero. So once you've decided who you can offer self-collect to, what should you discuss with them to help them make their choice? Well, probably what's at the very front of their mind is this test as accurate as the test I used to have before, the physician-collected test? And you can absolutely assure them that it is as sensitive as a clinician-collected test. The other thing, according to studies that women worry about, is, you know, the responsibility of testing is now shifted. You know, you as a doctor used to do the test for them, and now they're having to do the test. And if they do it wrong, are they going to get a false negative result? And you can reassure them, absolutely reassure them of that there's quality control measures in place that make sure that if the test isn't done right, that it will actually be reported as unsatisfactory or invalid rather than negative. And in fact, the most common cause of unsatisfactory results is a lack of cells. And that can be due to the fact that the patient actually hasn't done the test. So we think particularly possibly in the underscreened population who are more anxious about testing, they may actually be doing air swabs if they're sort of unsupervised whilst they're doing it. It's possible also that atrophy plays a part in this. It may be difficult for some women to get the swab past the keratinized vulva. You know, they may have some introitus shrinkage. It may be helpful to help them do the test. You can also lubricate the swab with normal saline if you think that would help. Estrogenization may also help as well, because A, it makes it easier for them to do the test, but B, it will also increase the cellularity of the vagina. The second most common cause of unsatisfactory results is contamination inhibiting the assays. And In fact, any vaginal application at a high enough concentration can cause inhibition. So things like canesten and certainly lubricants, particularly lubricants with carbomer in them, any kind of things that are used in douches, if they're used in a high enough concentration, they won't always cause inhibition, but if it's a high enough concentration, they can cause inhibition. Now, with blood and discharge, so with menstruation, they really takes a very high concentration of blood to inhibit the process. So especially if you think it's unlikely somebody will return for screening and you have an opportunity, even if somebody's menstruating, it's probably worth asking them if they could do a self-collect. If they are unlucky and if the blood is too concentrated and inhibits the assay, it's only going to come back as an unsatisfactory. So I think in most cases, it's worth persisting with a self-collect if possible. Again, discharge has to be at a very high concentration to inhibit the process. So we found at BCS that the unsatisfactory rate of self-collected samples is probably of the order of about 2%, which interestingly was probably the same as our rate for unsatisfactory cytologies. It can be, the cytology processing can be much higher than 2%. It is actually very operator dependent, but at BCS ours was about 2%. The unsatisfactory rate for clinician collected samples is 0.2%. However, we really can't draw too many conclusions from this yet, because we have to remember that self-collection is being done in a very different population, in the underscreened population. And I've already mentioned that it's possible that some people aren't actually doing the tests, or doing air swabs. And it's possible also that underscreened populations use lubricants more often. So we really can't, you know, this is early days at this point really to be drawing any conclusions from these results. So once you've discussed these important basic points, you probably need to discuss with the patient to help them make their choice the disadvantages and advantages of both methods. And of course, the most important disadvantage of self-collect is that you don't get cytology whilst you can do the cytology on the thin prep. Now, as far as management of results goes, 90% of people will be HPV negative. So in both the clinician collect and the self-collected case, the patient will return in 5 years. So that's really not much different. Now, if the patient returns an HPV 16 or an 18, and that happens in 2% of cases, as far as the patient's concerned, the management is going to be the same, because they will be referred to colposcopy with both clinician collect and self-collect. But there is some difference in the process, which I think it's important for you to be aware of. And that is that if they have a clinician collected sample and they're positive for 16 or 18, they will actually have a cytology done on that thin prep sample. Now, that's not for triaging whether they go to colposcopy or not, but my understanding is that some colposcopy clinics do use it to triage when they will get the colposcopy. Now, with self-collect, the guidelines don't require that the patient return to do that cytology. And in fact, that cytology gets done at colposcopy, but obviously it can't be used for triaging the point at which they have their colposcopy. So the main difference of management of results obviously happens with the patients who return a not 16, 18 result, and that's on average in about 6% of cases. So with a NOT 16/18, we need that triaging cytology to see whether the patient should go to colposcopy or not. And obviously we can do that on the clinician connect, but we can't do that on the self-collect. So we need to ask the patient to return for a clinician connected sample so that we can do that triaging cytology to see whether they need to go to colposcopy. If it's high grade, obviously they go to colposcopy. Normal or low grade, they go through that follow-up process I discussed before to see if they can clear the infection. If they have an unsatisfactory HPV test result and you're doing clinician-connected samples, obviously they need to repeat in 6 weeks, because you want that squamo-columnar junction where you collected those cells from for cytology to regenerate. Because with a clinician connected, you can use a cytology, you can process a cytology. However, with self-collect, you're not doing cytology, so you don't need to worry about regeneration, and you can actually, you're just doing an HPV test and you repeat the test at your earliest convenience. With HPV NOT 16/18, it's also important to be aware that it varies very much with age as to the percentage of the population that get positive results. So a young person is much more likely to get HPV NOT 16/18 than an older person. And that may play into which choice the patient decides to make. So also be aware with HPV NOT 16/18 that if they've come up as positive for NOT 16/18 once, when they go for their follow-up test in a year's time, about 50% will be positive again. So that's quite a high percentage. So if you've already got the patient in the office, they're not that worried about a speculum examination, it may actually be easier for them to have a physician collect, bearing in mind that quite a high percentage will be positive again on their follow-up test. This resource is something you can find on our BCS website, and we've also got these resource cards at BCS, you can order them. And this pretty much sums up what I've discussed, and I think it's quite useful to have when you're talking with a patient about their choice. So you've also got to discuss with the patient how they take the self-collect sample. And a lot of women worry about getting to this red mark on the swab, and they can't see the red mark, so how do they know whether they're there? And maybe it's a good idea to advise them just to put their finger on the red mark so they can feel when they reach the red mark. But the other thing to be aware of is the swab really doesn't have to go that high, just needs to get past the keratinized area of the vulva. So what swabs do you use? I think the most commonly used swab is this 552C or 552C.80, but you do need to check with your lab. At BCS, we process both those swabs. We also process a white top swab as well. Do be aware that you can do chlamydia and gonorrhea on these swabs as well. You can also do chlamydia and gonorrhea on ThinPrep too. At VCS, we can process swabs that are taken during pregnancy, but you can't always do, not all labs are accredited to do that, so you need to check with your lab. The swab has to be processed within 28 days, so if you're sending them home with the swab, you must make sure that they put the date of collection on the sample and on the request form. Some labs require you to resuspend the sample into a thin prep vial at the time of collection. So you basically swirl the swab in the thin prep solution. And if you are doing that, if you do have a lab that requires you to do that, you must really make sure on your request form that you indicate that it is a self-collected sample. Otherwise, they might think it's a physician collect and process the cytology if it's needed. And of course, it will be invalid if this is a self-collect. So where can you perform self-collection? Well, as you know, it must be ordered and overseen by a healthcare professional. Only doctors and nurse practitioners can sign the request form. But other than that, the models can be really quite flexible in order to accommodate the best success of screening. And the healthcare professional can assist with the sampling and it's still called a self-collect, or the doctor cannot be present when the sampling is occurring. And, you know, as you know, you can even send them, they can even take the swab home. And VCS even has a process whereby you can actually just send a kit to them. So basically it would work that you discuss screening with them on, say, a telehealth consultation, and I don't know, say they're an agoraphobic patient or they can't leave their house, so they can't come into the surgery to pick up any equipment. We will, if you send a request form to us, either through a fax or a courier, we will send them a kit which will, with instructions and the swab and a reply paid envelope. And then the idea is that they send the swab back to us within 28 days of sampling. And remember, they have to put the date of sampling. And then we will send the results to you. And we will also let you know if they haven't sent the results through to us. I mean, sent the swab through to us. All this having been said about the flexibility of the model, it is felt that clinic-based sampling gives the best opportunity for a successful outcome. Like studies have shown that they're more likely to do a valid swab if they're sampling in a kind of clinic-based situation. So I'm now going to talk about results follow-up, using a case study and some questions to sort of promote discussion. So we've got a poll that Hannah's handling. Thank you, Hannah. So I'll just read through the question and then Hannah will open the poll. So we've got 29-year-old Nadia. She's a new patient. She's pregnant and said she's never had cervical screening. And she's extremely anxious about the process. Can you offer her self-collection?
I'm just going to give a moment for everyone to pop the answers in. All right.
Okay.
We'll close off that poll now and we'll have a little look at the results.
Okay. So, yes, most likely you can offer her self-collection, but I actually like that it's a bit tricky, this question. I actually like the need more information answer better, because you need to check that she hasn't got symptoms, because if she has symptoms, she will need co-testing for investigation. The other thing you might want to check and need more information about is, are you using a lab that will process self-collects during pregnancy? And the other thing just to think about is, has she really never been screened? You might want to check her history, see if she's on the registry. Sometimes, particularly if English is a second language, They might not realise that they've had a screening test before. So those are a few things that you might want to think about, but certainly, yes, as long as the lab that you're using will process these swabs in pregnant women, and as long as she hasn't got symptoms, she probably could have a self-collect. Okay, so moving on to the next part of this. Oh, so I chose this off first of all, Hannah?
Yeah, you can do that. You might just need to click on your screen again to
okay, that's what's happened.
activate it.
Okay, so part two. What are some of the things you might discuss with Nadia to help her make her choice? And there's multiple options here. So would you say to her self-collection is just as accurate as physician-collected sampling? Is that something you bring up? Would you say to there is a chance of about 4% that she may need to return for a physician-collected sample, because that would be because she was not 16/18 positive? Or would you say to her that there's about a 17% chance she'll have to return for a physician-collected sample? Would you also say to her that she must be very careful to do this correctly, otherwise she will get a false negative result? So as I said, there are multiple answers that are right here. So you pick what you think are things that you would say to this patient. Okay. So right, that's great. I mean, this is probably the most important point to get across, that it really is just as accurate as physician collect. That's perfect. The second point, that's if she was older, 4% would be right. So probably the age group of about 40 have a 4% chance of HPV non-16/18, but she's a younger woman, she's 29, and actually that age group, 25 to 30, their chances of not 16/18 are about 17%. So she has a 17% chance that she might have to return to have a triaging cytology done. She doesn't really, you don't really need to, I suppose, I mean, you wanted to do the test right, but you don't want her to get anxious about doing it. And if she doesn't do it correctly, she won't get a false negative result. It will simply come back as unsatisfactory. So I don't know that I would say that to her, because I wouldn't want to get her anxious about actually doing the test. The next part of the question. Oh, hang on. So she chooses self-collection, but refuses to do it in the surgery and asks if she can take the swab home. Is this allowed by Medicare, yes or no? Yeah, that's an easy one. That's right. So she can take it home. That's not a problem at all.
Everyone got that one right, Alexis.
Yay, yes. Woohoo! So move on to now the next part is a bit tricky. So you're really pleased to see that she's done the test as required and dropped it in, but of course the result is HPV not 16/18 positive, as luck would have it. You tried contacting her to return for a physician collected cytology sample, which you're meant to do to triage the result, but she doesn't turn up for the appointment. She eventually makes an appointment for her postnatal check 3 months after she's had her baby, but this is 10 months after she's had her original test. So after the test result was returned as a not 16/18 positive. After the experience of childbirth, she's a little bit less anxious about speculum examination. you discuss her options. So which of these tests would be the best option, do you think, for this lady? So either a physician-collected cytology, HPV self-collection, physician-collected CST, physician-collected co-test. I'm going to open the...
We might leave this one up for a minute or so, just to give people a chance to have a think.
Okay.
We'll just give it another moment. We've still got a few people answering. All right, I'm going to close that one off now. So we'll have a look at the results.
Okay. So physician-collected co-test, I can see why you think that might be a good test to order, because that was, after all, what we were chasing earlier on, to get that triage in cytology on that not 1618 result, and to see whether she should go to colposcopy or not. But we've really, you know, it's quite a long time ago, this result now, so really getting a triage on it, it's probably a bit past history. And really what we want to see is, has she cleared the infection? And as I said, with the labs, they allow a 3-month leeway. So she's 10 months after her original test. We could probably do it. It wouldn't, if she's very anxious about having a speculum exam, it would probably, it's a good choice to offer her an HPV self-collection, because she is in the high-risk group we were talking about, who, because she's under-screened, if she's positive for this HPV not 1618 on her follow-up test, she will go directly to colposcopy without a cytology. So she wouldn't have to, so it's actually quite a good choice to think about offering her an HPV self-collection. It also assuages her anxiety because she's having self-collection. And as I say, she wouldn't, in this case, if she was positive again, have to return for the cytology. She could go straight to colposcopy according to the guidelines. Now, the other option here, I think physician-collected CST is also a good option if she didn't mind having the speculum. And I think because we've said here that there's a 50% chance that she's going to be positive on her follow-up, not 1618. And the colposcopy nurses would probably thank you for doing the physician collect, because they would then have that cytology on the sample, which is not the triaging cytology to see whether they go to colp, but it's a cytology that's done to inform the colposcopy gynaes and nurses, and it can be used, the clinics use it for deciding when they're going to do the colposcopy. So that's also a good option, although, you know, if she's too anxious, I would definitely just stick with the HPV self-collect, because as far as going to colposcopy, you don't actually need the triaging cytology. So physician-collected co-test. If she had symptoms, this would be a good one to order. But if you ordered a co-test per se, it's not actually covered by the MBS under these circumstances. So this would not be be processed, basically. So it would only really be if she had symptoms that you could order a co-test. So no more. If you want to discuss that a bit more after this, I'm happy to go through this question again. And here we go again. This is a diagram referring to the last case, which actually just emphasizes that you don't need to have a cytology to triage the self-collected HPV as far as going to colposcopy goes at their 12 and 24-month follow-up. So 12 months, the high-risk group, they won't need this triaging cytology, so they can have a self-collect done, and the 24-month follow-up group don't need a triaging cytology. So they also, it's quite useful just to do a self-collect. So that's the end of my presentation, but I will be taking questions and answers later. And I think Ella Elwood-Shoesmith is now going to talk to you about the health pathways. Thank you.
Thanks, Alexis. That was really informative and a great summary, I think, of where things are up to. I look forward to the questions to come. Just a little bit of info tonight on health pathways and how it relates to tonight's discussion. So for those of you that don't know, Health Pathways is an online resource written by GPs and designed to be used in general practice. It's really aiming to provide locally agreed information that allows clinicians to make the best decisions at the point of care. The pathways are written to be used during the consultation and really designed to provide clear and concise guidelines to help you assess and manage a patient with a particular symptom or condition. Health Pathways includes local referral guidance on when to refer, where to refer, and what to include in the referral. The pathways are really developed as a collaborative effort between local GPs, between non-GP specialists, between allied health providers and other subject matter experts. So the idea is that the pathways are evidence-informed, but they're designed to really reflect local reality. Health Pathways aims to enhance clinical knowledge and promote best practice, to reduce variation in care, to really streamline the quality of pre-referral workup, and importantly, to provide you with resources and services available for your patients in your area. So tonight we're just going to have a quick look at the cervical screening pathway, but other relevant pathways to tonight's discussion are the non-acute and acute gynae pathways for referral, colposcopy referral, and the cervical cancer pathway, of course, as well. So looking at the cervical screening pathway, you'll find a bit of a background section with some info that may help to explain the program to your patients and some of that useful kind of bits of data that Alexis has pointed out tonight in terms of numbers. The assessment section includes lots of information, including particular patient groups that may require variations to routine screening. So immunodeficient patients, for example, those who've had early sexual activity, or management of patients post-hysterectomy. We've got drop-down menus around the National Cervical Screening Program, and obviously lots of information about self-collection itself in terms of who is eligible. Again, info about the validated swab types and who's not eligible, as Alexis has outlined tonight as well. The management section has divvied up into clinician-collected management and management of self-collected swabs. And again, with some links to some really useful things, again, this flowchart that Alexis has shown us tonight. So links to really useful things you can think, oh, I know I saw it somewhere. Chances are you'll find it in the pathway and you can access it that way. Also some info there about follow-up in terms of what patients might expect to hear from the registry in terms of reminders, invitations, recalls, etc. For those patients who do need referral, the pathway outlines when and where to refer patients, and there's lots of handy info both for health professionals and patients at the end of the page. So Health Pathways Melbourne is available to general practice teams and other clinicians both in the Eastern Melbourne and Northwestern Melbourne PHN catchments. To access Health Pathways, you go to that website address melbourne.healthpathways.org.au. If you don't have access, you can register through the pathway via that QR code or through emailing the team info@healthpathwaysmelbourne.org.au. As always, we love your feedback. So if you're using this page or any of the pages, please feel free to click on the send feedback button and give us some info that will be sent to one of the clinical editors to act on. That's it from me tonight. So thank you very much. Back to Alexis and Hannah for question time.
Fantastic. Thank you very much, Ella. And yes, it is a very useful tool. Thank you for your presentation as well. All right, so we have got about 10 minutes for questions at the end. So I'm going to hand back over to Alexis, and I'll get you to speed through as many of these as you can, Alexis, in the time we've got left.
Yes, so I'll start off with, okay, I'm just going to go through everything. If I cannot locate a cervix for CST with a speculum examination, can I sweep the vaginal vault with the cervical brush, or do I need to use the self-collection swab, and what do I put on the platform? Okay, so I would use the self-collect swab and call it self-collection. That's basically an assisted self-collection, and that's fine. And then another, I hope that's answered that question. Another question here, is COMPASS trial still going? And the never-ending COMPASS trial. There are still some women who are in the COMPASS trial. It's almost, they certainly have stopped recruiting years ago, but there's still some women who haven't finished the trial yet, but very few left, really. I reckon they'll almost be all finished in probably about a year or two. So that's the answer to that one. What rebate you are talking about? That's the Medicare rebate. When I was talking about that, I really meant, you know, if they ask to be screened not at the correct screening interval, they won't get a Medicare rebate, which basically means their costs won't be covered, and so therefore they might get an invoice from the lab. That's what I was talking about there. Does Medicare have an item number for the underscreened people? It has a couple of ones under the 2-yearly screen regime. I don't think so. I don't think so. I'm not sure about that. I'm not really quite sure what that's getting to, but I don't think Medicare has separate item numbers for people who are underscreened. It used to be in the past that only underscreened people could access self-collection and get a Medicare rebate. This may be what you're referring to. That's all changed. That isn't happening anymore. That was prior to July 2022. Now it doesn't have to be that you're underscreened in order to access the Medicare rebate for self-collection. Sorry, did you say it's okay to dip the swab in normal saline? Now, the head of our molecular lab, who does all the HPV screening, who runs all the protocols and stuff, I've asked him specifically about this. He really likes the swab to, if you're going to do this for lubrication, he recommends getting those normal saline capsules and just squirting the swab, not actually dipping it in normal saline, just giving it a little bit of lubrication with normal saline. And he says that that's okay, if that helps. Other than normal saline, what other lubricant can be used for self-collect? So I would try not to use any other lubricant, really. Certainly not, try to avoid using gel lubricants if you can. If somebody's struggling with it, maybe helping them, I think, is the best way, really, to help them with the self-collect swab, actually sort of assisting them. So can chlamydia PCR be performed on the same sample sent for HPV? Most certainly, yes, and gonorrhea, and we're hoping in the future trichomonas and mycoplasma. Can you do a cytology of the self-collect sample put in a thin prep bottle? Definitely not, because you've not accessed the squamo-columnar junction. Self-collect, is there a risk of swab broken in the vagina? Oh, we haven't come across that yet. I suppose anything's possible, but it's not something that I've come across. In terms of timing of both self-collect and condition collect, what is the best time for screening postnatal women? I think with HPV testing, it doesn't matter. But when you're talking about cytology, as you know, the postnatal period isn't so good. So if you're doing a physician collected, the cytology isn't so good in the postnatal period. I mean, leaving it for 6 months would be better, but it's always a balance of how likely you are to get the woman back. And if you think, they may not come back for screening, obviously it's just better to do it at the postnatal check. But it's better because of the lack of estrogenization of cells postnatally. It's better to leave it for a bit longer and do it a bit later at about 6 months. But as far as HPV testing goes, it doesn't matter. You can do it immediately postnatally. Right. Can I get clarification? Is co-testing only done in the setting of concern for abnormal cancer cells, e.g. setting postmenopausal bleeding? So is co-testing only done, my understanding is co-testing is only done in the setting of concern of abnormal cancer cells, e.g. postmenopausal bleeding. It's mainly done when you want to investigate symptoms that you have concerns that they may be from cervical cancer, but there are other reasons for doing co-testing, as I discussed, test of cure surveillance. If you look on our website at this, there's a bit more information about this, but yes, there are other reasons other than just investigating to exclude cervical cancer. In terms, right, I've done that one. Right.
It looks like we've got to the end of the questions that we had.
Yeah, sorry, some of them got into chat, so I'm trying to.
Yes, no, I've just had a look through, and I think we have.
Okay, good.
So well done, Alexis. You motored through them. That's fantastic. And if there's any other questions after this session as well, you are always welcome to call us at VCS Pathology. Our liaison physician team are always happy to help and to answer any other questions after this session as well. So, all right, we are at 8 o'clock. So I'll just like to spend the last moment, the last minute, just wrapping up with a couple of things to bring your attention to. Can you see my screen there? Okay, Alexis?
Yeah, I can see your screen.
Fantastic. Okay, so just a couple of things that we'd like to bring your attention to, and the first is a couple of online courses that the ACPCC have available with our partner organisation GPEX. These are RACGP accredited courses, and they're fully online and can be done in your own time. The first is this cervical screening HPV and self-collection course, which is really more of a deep dive into the cervical screening program. It's got a real focus on self-collection and improving screening rates for under-screened communities. And it is accredited with the RACGP for 4 educational activity hours and 2 hours of reviewing performance. The second one is our breast, bowel and cervical cancer screening online course, which covers the 3 screening programs, as well as offering tips and to identify and support under-screened patients as well. It's also accredited with the RACGP for the hours shown on the screen there. And all of these things will be sent to you in a follow-up email after the session, which will probably go out early next week. But encourage you to have a look at those courses if you want to go a little bit further and learn a little bit more about cervical screening, as well as the other cancer screening programs we have available in this country as well. Just a very quick plug for some of these beautiful resources that we have partnered with the Victorian Aboriginal Community Controlled Health Organisation to develop. We're providing these resources for Aboriginal and Torres Strait Islander people, and we have self-collection kits as well as coverings available for clinician collected tests, and they all feature this beautiful artwork by Madison Connors, who's a proud Yorta Yorta, Jaja, Wurrung and Gamilaroi woman. If you do practice in Victoria, these resources are available to Victorian practitioners who work with Aboriginal and Torres Strait Islander clients. If you are interested, you can order these resources for free by contacting Barcho on the details shown on this slide, which will once again be shared with you post-session. Just lastly, we're also putting the word out about some research that the University of Melbourne are doing and are really keen to hear from you and your colleagues about. They're wanting to learn more about your views and experience with self-collection, even if you've never used it before at all in your practice. The survey is called Supporting Choice, and a link will be sent to you in the follow-up email. So really encourage you to do that, and for your colleagues, encourage your colleagues to do it as well. Lastly, there is further support available. You can always contact our wonderful liaison physician team, including the lovely Alexis herself, and we're always happy to answer any questions, regardless of whether you use our pathology services or not. And we can also organise further education and support for your practice too, so don't hesitate to get in touch. For health pathway support, you can contact via this website and email. And if you're in the Northwest Melbourne PHN catchment, you can get in touch with their team or reach out to your local PHN, particularly if you need further support to access the NCSR, for example, because they can certainly assist you with getting this set up. All right, finally, and apologies, we have gone slightly over time. We do value your feedback, so we ask that you take a minute or two to fill in an evaluation survey. You can scan the QR code here, or there will also be a link that's posted in the chat. Apologies, I'll just leave that up there for a moment. So thank you everyone for joining us. Thank you so much to both our presenters tonight. And thanks to the Northwest Melbourne PHN for partnering with us and making the event possible. I'll leave the QR code up. Please fill in the survey and enjoy the rest of your evening.